So what have we done? We've had an incremental change. We've ditched our medical management role, our bed management role. Our bed managers were working at the front to put people into beds. We're now getting them to work at the back, getting people out of beds. So we've made an explicit direction, and we're redesigning things, and we're working on a daily basis to make it clear to heads of department and clinicians that they are actually responsible for the beds. So this is what I mean. 6 months ago, if you're in the emergency department and you had a respiratory patient who needed to go to a respiratory failure unit or ward, you were the emergency physician, you'd put in an electronic booking slip, or you'd put in a notification that they needed a bed. And someone would ring the ward if they didn't ring in a certain time and say, you know, have you got a bed? And half the time they'd say, we haven't got a bed. No bed. So what happens then? Think about what would happen then in your hospital. So what happened in our hospital, if we go, oh, we haven't got a respiratory bed. What's plan B? So then we'd go to a group of bed managers in an office who'd know where all the beds were, and they'd say, well, you know, respiratory, probably could go to a geriatric unit, we'll put them up there and we'll slide them in and it'll be okay, and then the next couple of days we'll bring them back. And so 50% of our bed moves in the hospital on any given day, we're actually getting people back to their home wards on day 2 or 3, incredibly inefficient, bad for infection control, and we had outliers. Because the very first conversation was, sorry, we don't have a bed. And then we got bed managers to solve the problem. So now we don't have that conversation anymore. We say, there's a respiratory patient in the ED, they're coming to you within 2 hours. That's it. There's a coming ready or not signal. And there is a consultant on for that team, respiratory, who may or may not be the head of department, but he's probably on call that day, but he's now, or she, is very, very clear that their responsibility is to have an overview of what's going on in respiratory for that day, the next day, and the day next after that, and to be proactively managing their capacity and making sure they've got a bed. Which means sometimes they have to go and see other consultants' patients and discharge them on their behalf. It means they have to go and do some problem solving. So when we brought this in, you know, the head of surgery comes up to me and goes, well, you know, I've got 4 patients in the hospital right now who could go home today. But you know, one needs this and the other one's that, and they can't go home. And right now, today, you've got somewhere between 18 and 24% of your patients in beds that don't need to be there. We've done the studies over and over and over again. It's a remarkably congruent number, 18 to 24%. So I said to Jose, oh, Jose, you've got 4 patients who could go home. So what have you done about that? Because it's 2 o'clock in the afternoon. We're having a meeting about something else, you know. What have you done? Who did you tell? Who did you call? I don't know. No one? No, that's not my job. And it's true, busy surgeons can't necessarily know how all of these systems work. So we've turned our bed managers around, and now their job is to help solve those problems. So when he says, actually, one of my patients needs to go 1,200 kilometres north to Exmouth Hospital, but they can't do vancomycin levels, and that's why they're still here, rather than keep them in hospital an extra week because we can't do vancomycin levels, somebody in the hospital will know how to solve that problem in the next 2 hours. So our bed manager's job is to know who that person is and solve the problem and get the patient into a transit lounge onto a plane to Exmouth this afternoon, rather than having to say another day. So we're solving problems at the back. But the consultants have to identify the patients who can go home and be thinking, well, it's Friday and I need to have 6 beds on Monday. How is the team going to work over the weekend to make sure I've got the 6 beds on Monday? So we've been doing this for about 6 months now, and it's early days, but we're seeing success. And it's consultants, it's only consultants who have the privilege to admit and the responsibility to discharge. So they're the only bed managers in the system, really. In our system anyway. So where we've brought in these kinds, these are the issues that I'm talking about here in that system. We've done a hot floor. So when you've got 100 admissions a day and they're going to 15 different places, respiratory, haematology, you name it, each of those individual destinations doesn't get good at pulling patients and managing capacity. So we're trying to minimise the number of routes into a hospital. It also makes things a bit safer because you don't have patients going to the bone marrow transplant unit in the middle of the night or somewhere else. That's probably not a good example because that would be an infection control issue. But you don't have people in one admission in the middle of the night going to one isolated ward. You have them going to one place. And you can actually rationalise some of your on-call rosters and things like that as well. We're improving our staffing profiles, and we've engaged all our heads of department in an iterative process to improve our reporting dashboards, which have performance, quality and operational endpoints. We're doing a frontline leadership program where we're training our heads of department and nurse unit managers to work together to deliver certain things. But what I'm including giving them homework and master classes